Okay, again, thank you for the kind introduction. And I would really like to thank Dr. Lauren Kelly and Dr. Megan Azad for giving me this opportunity to present here at the last seminar for this year of SOCRA, Society of Clinical Research Associates. So, although Tarban introduced me, I am an MD PhD scientist by training, and my research interest is the developmental origins of health and disease, and specifically growth, cardiometabolic health, and since I moved in Canada, asthma, allergies, and continuing the cardiometabolic health pathway. I'm interested in the role of nutrition and genetics and their combined role in the development of these health conditions. So the way I've structured the talk today is, firstly, I'm going through the developmental origins of health and disease. I'll walk you through some key definitions and the strongest evidence and the first evidence towards the field, the DOHaD field. And then I'll briefly go through the cohort study characteristics, the designs and advantages and the disadvantages of cohort studies. And lastly, I'll spend a bit time on cohort study examples for DOHaD research. So when we talk about the developmental origins of health and disease, we need to understand that to understand where we're going, we have to know where we've come from. So we need to realize that early life environment is critically important to our risk and resilience across the life cycle. This means that we need to be aware of our environment across this entire lifespan or the entire life course. And this includes the preconception, can you see my mouse? The preconception period, which I haven't shown in here, but it will be the examples here. This is really critical period in our life, that it's not only important to mothers, but also to fathers. And we can go back to adolescence, to boys and girls, to our parents and grandparents. So because as a healthy start to life may lead to a healthy adult life, also an healthy adult life may lead to a healthy start of life. When we talk about the developmental origins of health and disease, there are two key descriptions, or two key, So firstly, we start with the first description, or the first key, I forgot the word, the key definition, which is the fatal programming, or as also known, the Barker hypothesis during 1980-1990. Where it stated that environmental exposures during critical periods of fetal development may influence the adult health. However, in 2000, we go with a broader definition where not only the fetal period is important, but both the prenatal and postnatal environment shape the developmental trajectories that influence health throughout the life course. Anyone, I know that there are people in this room that know who is in this picture, but do you know who is the person in the picture? I knew that you knew it. So David Barker, as we heard before, in 1980-1990, he was the one coming up with the fetal programming hypothesis or definition. But when we think further ahead in time, from Hippocrates or Aristotle, this concept was already known. So what did David Barker and why? How did he come with this fetal programming hypothesis? So during the early 90s, in Hertfordshire, England, there was a high risk of death, and from the medical records that were recorded during that period, so records of birth weight, weight at 1 year, records of illness and development for each baby born in that specific place, Barker and his colleagues realized that low birth weight was the common cause and the most important cause leading to deaths during that period. So They hypothesized that if an infant was born low to birth weight but survived during childhood and adulthood, as an adult, they were going to have some optimal, compromised health. So, having those data, they were able to track these children and see their later outcomes. This is one of the first studies published from those data, when in the x-axis you can see the birth weight in pounds for male and female separately, and on the y-axis you can see the mortality ratio. As you see in the x-axis, we are not talking about categories of extremely low birth weight or restricted growth in utero, but we are talking about the normal ranges of birth weight. And this graph shows us that infants or adults that were born with low birth weight within the normal ranges, so less than 5.5, they have higher rates of mortality from coronary heart disease. And these findings were similar for type 2 diabetes and lipids profile. So, Barker and babies, so in this case, when we talk about birth weight, it may be that birth weight is a surrogate of other conditions in utero. It may be a surrogate of restricted growth. It may be a surrogate of malnutrition or other conditions during the womb period. So other epidemiological evidence has shown that it's not only birth weight, a factor that may lead to all these adverse health outcomes, but trajectories as well, early infancy as well. It's very critical in terms of development of adverse health effects. So what we experience as individuals in early life can shape our later health outcomes. Convincing evidence also comes from the Dutch winter famine, or the Dutch, as known differently, the Dutch hunger. That period was a very tragic natural experiment. So the Dutch hunger winter happened during 1944-1945, during the war. Because of the German Nazi rule, there was an embargo of the rail transportation to the Netherlands. At the same time, that was accompanied by severe winter conditions. So from a population in the Netherlands that it was well nourished, it happened that during this period of winter 1944, spring 1945, they went in and malnourished, like they changed completely to malnourished. Until the spring of 1945, when the Allied forces liberated the Netherlands, the rail transport could come back, and the population became well nourished again. So Tessa Rosseboom, as you can see in this picture, and her colleagues went in the birth records that were collected during that time, trying to see what happened to the individuals that were born from pregnancies during that period. And what they found was really interesting, because the time during which a woman was pregnant and experienced the famine determined the spectrum of the disease phenotype in her offspring as adults. And these findings shows that infants or women that enter pregnancy in early gestation, women that entered famine in early gestation, their infants or their children are the ones that had the most adverse effects. So their infants, and in an older, their adult children now, they had glucose intolerance, type 2 diabetes, obesity, especially seen in females, like several adverse effects, health effects, and among them also, I have to move this here, breast cancer. So it was seen that adults of women that entered famine during early gestation, so that they went through famine during early gestation, they had the most adverse effects. So these examples show us that there is something in common. They are looking at exposures during early life, so fetal life, and also early life, like the first 1,000 days, as we say in the DOHaD field, and they follow up these mothers and children until later in adulthood. So, in my research so far, during my PhD and my postdoctoral studies, I'm looking at fetal growth and birth outcomes, kidney development, and hypertension. So trying to understand factors that influence in the development or alterations of these outcomes. And during my postdoc, allergies, asthma, and metabolic syndrome. So the most common approach to explore a DOHaD research question, or what is done mainly so far, the types of the studies that we use are cohort studies or observational studies. So what I explained so far, it's all observational data. In epidemiological studies, we have different types of studies, starting from descriptives, observational, where cohort studies are one of the main components, and experimental studies. If we see the hierarchy of the study designs, among the observational studies, cohort studies are at the top of the hierarchy. So among the observational studies, they allow us to also observe, to also establish causality or in the associations or in the relations that we are exploring. So for example, low birth weight and coronary heart disease. But what is a cohort study? What does a cohort study study? So a group of individuals that are followed for a period of time in such a way that new events, in terms of events, we have health outcomes, disease or death, or changes in their characteristics are detected. So we start and we follow up the population that we enroll until an adverse health outcome or changes in the phenotypes that we are exploring are detected. So these new events and changes can be related to the baseline observation. In case when we see that a disease happens, we go back in time and see, is this individual exposed to a specific exposure or is it not, or the other way around. So what are some of the characteristics of cohort studies? Cohort studies are the only one I have to acknowledge that I have borrowed these slides from my mentor, and maybe some of you have seen them before. They address temporality, so they are the only studies among the observational studies that can be thought as going from the cause to the effect. So we don't know sometimes we don't know which is first, is it the chicken or the egg? But cohort studies give us the opportunity to understand which is the cause and which is the effect. They permit the calculation of incidence rates, so which are the new cases, permit investigation of multiple exposures, and also explore common outcomes and diseases. When we talk about the cohort studies, it's important to acknowledge that there are two types of cohort studies, prospective cohorts and retrospective cohort studies. So prospective cohorts, we go from present to the future, and retrospective cohort studies, when we are now in the past, we know what has happened, and go back to see if this individual was exposed or not exposed to the specific exposure that we are interested in. In the prospective cohort studies, we can directly measure the exposure. So if we're interested on what is the blood pressure or what's the exposure of carbon dioxide levels, we can directly measure the exposure and then follow the individual through the time and see if they will develop or not the disease. While retrospective cohort studies, they rely on the data that's already obtained. So we don't have much opportunity to go and to think of the exposure that we really wanted, because we have to rely on what we already have. We have to acknowledge as well that prospective cohort studies take a lot of time. And I'll give you some examples. I'll show you some examples later. So they are slow, and we must wait until the outcome or the phenotype occurs. Well, in retrospective studies, we know we already have the data and the outcome, so we just need to go back and obtain the data. However, the prospective cohort study are the best because they provide the most direct evidence for a cause-effect relationship. Retrospective still provide good evidence, but they are they may be biased. So which are the steps to perform a cohort study? I know that there are experts in this room, that they have done it already, have started studies from the scratch, and they still go on. But firstly, we select the study population. Then we obtain data on exposure, and we select a comparison population. We follow up the population, we obtain the data, and then finally we analyze the data, which is what I've done so far during my PhD and postdoctoral trajectory. So in terms of the selection of study population, usually in cohort studies, they come from the general population, so a specific geographical area, like the Rotterdam study in the Netherlands, or a group that may be easy to identify, such as the nurses' health study. And I'd like to show you a video.
The Nurses' Health Study was established by Dr. Frank Spicer in 1976 with funding from the National Institutes of Health. The primary motivation for starting the Nurses' Health Study was to investigate the long-term health effects of the use of birth control pills, or the pill. The pill was a fairly new drug at this time and was being prescribed to millions of women. In 1976, registered nurses who were married and aged 30 to 55 were recruited to enroll in the study through state nursing boards. These nurses resided in California, Connecticut, Florida, Maryland, Massachusetts, Michigan, New Jersey, New York, Ohio, Pennsylvania, and Texas. We chose to recruit registered nurses because we anticipated their education would enable them to respond with a high degree of accuracy to brief, technically worded questionnaires, and these women might be motivated to participate in a long-term health study. 121,700 women responded to our baseline questionnaire and became the first group of participants in the Nurses' Health Study.
So, as we heard in this short video, we heard a large number, like 1,170 something women. So it's a large population that was needed. And secondly, we heard that they had a specific criteria. Why did they select it? Were there any other criteria in the video that you heard about the selection of the study population? Like why specifically these, and what were the criteria that they chose? For example, was there any specific age range of the? Yeah, and why was that? Yeah, so we see that before we design a cohort study, we need to have some selection criteria. In this case, it was the education level, it was the age. So we have these are some of the criteria we have to take into account when designing a cohort study. Do you remember during the video, what was the way how they obtained the data from the nurses? Exactly, it was from questionnaires, but there are other ways how you can collect data from cohort study, and we have experts in this room that for the child study, they have gone in the houses, they welcome participants, they go to one-to-one interviews. So there are different ways how to collect data for how to obtain data in cohort study. Another important aspect for cohort studies is the follow-up. So it's not that we obtain that we gather the data, that we get our study population today, we obtain the data today, and that's done. No, we have to follow up these individuals for a long period of time. Especially with the birth cohorts, we need to follow up the children and the mothers and the fathers as well for a long period of time until an exposure or until the outcome happens, until hopefully not, but the disease happens. So how we do, it's really critical to do periodic examinations for each of the members of the cohort. It may be by reviewing physicians or hospital records, by routine surveillance, by mail questionnaires, telephone, or study visits. So which are some of the advantages and disadvantages of cohort studies? Let's start with the advantages. So we gather data regarding sequence of the event. So this is something that we can address temporality with cohort studies. We can examine multiple outcomes for a given exposure. We can investigate rare exposures with cohort studies. So by distributing questionnaires or by asking a specific question, we can get information on a rare exposure. We can calculate the rates of the disease. We can study common outcomes such as asthma, obesity, hypertension. And using cohort studies, there are lots of possibilities for collaboration and data sharing. There is the REACH platform here in Canada, which has gathered all the data data from several cohort studies, and that creates an opportunity for combining data and answering questions that need a larger sample size. However, there are disadvantages as well for cohort study, such as large numbers are needed. They are susceptible to selection bias. So, for example, we say that the nurses' health study. But what if, like now we have a really educated population, they are motivated to come in the study, but sometimes those findings may not be generalizable to all the entire population, because the way that the nurses answer a question, it's not the same way that that another person less educated from another region can answer that. Also, they are expensive to conduct, and they require a long time until the disease or the phenotype, the outcome happens. And maintaining the children and the parents or the participants in the study, it's difficult. So how do cohort studies help us answer DOHaD questions? There may be two ways. It may be prospectively. So we start with the birth cohorts, we enroll mothers in the study, we wait for the infant, for the babies, for them to deliver the babies, and we follow up the babies. But also it may be retrospectively. So we have the adults now, and we go back in the past and ask questions about their exposures. I had the chance to work with two landmark cohorts, the Generation R study in the Netherlands and I had the extreme luck to work with the child study here in Canada. So in the Generation R study, I defended my thesis focused on early life nutrition, growth, and kidney function in children. And this is a picture of my defense, where here you can see Tessa Rosseboom, the leader of the Dutch hunger studies, and Vincent Jadot, the leader of the Generation R studies. Both of them had the chance to work and be trained under David Barker's supervision. So what is Generation R study briefly? It is a population-based prospective cohort study has enrolled participants from early fetal life onwards. Almost 10,000 children are born between April 2002 January 2006. Mothers are enrolled during pregnancy, and during pregnancy they were seen several times. Then we have we saw the babies when the mothers delivered them at birth, at 3 months, 6 months, 12 months, 24 months, and then when they became more grown up at 6 years, 9 years, 13 years, and they're continuing to follow up these children. And it is a multi-ethnic population located in Rotterdam, the Netherlands. I don't want to scare you with this figure. I'm not going with this huge table. I'm not going into details in that, but it's something that I want to emphasize, the amount of data that the study has collected, and they are now planning the 13-year visit and planning to continue and following up the children in the study. So almost 10,000 mothers were enrolled, and some of the main outcomes that the Generation R study was interested was growth and physical development, behavior and cognitive development, diseases in childhood, and health and healthcare. And also the main determinants or the main exposures that they collected were biological determinants, environmental determinants, social determinants, etc. I'll briefly show you what type of determinants and outcomes I did use for my thesis and some results of the studies I worked in the Generation R study. So the main measures I used in the Generation R study were nutritional determinants of the mother during pregnancy and infant diet, fetal growth patterns. So during pregnancy, the mothers came several times in the study. They did repeated ultrasound. They were measured, so we were able to determine fetal growth patterns. And at the age of 6 years, I studied kidney health in children. So during fetal measurements, we had we distributed questionnaires to the mothers and asked questions about maternal diet. We collected their blood samples, and also they did repeated fetal ultrasounds. At birth, we obtained data from we obtained hospital data in terms of recorded birth outcomes, such as head circumference, length, or weight, and biological samples. So they obtained cord blood samples. During infancy, we distributed repeated questionnaires to the mothers, and we obtained data on infant feeding. And then at school age, children were assessed again, several questionnaires were distributed, physical examinations as well, and blood and urine samples were obtained. I'd like someone from the audience to read the title of this paper. Any volunteer? Thank you, Dr. Becker. So, can someone tell me what is the exposure in this paper from the title? Okay. Maternal vitamin D. And what's the outcome? And also risks of adverse birth outcomes. So, why do you think I needed a cohort study to explore these associations? And yes, I think John has one. Exactly. So we obtained data on exposure when mother came at the research visit, and then we followed the mothers. We obtained data on the outcome. So the exposure happened before the outcome. And I'd like you to show some of the results because I think they're really interesting, especially knowing that 50% of the mothers in the Generation R study and overall in the Netherlands, they are vitamin D deficient. So 50%, it's a lot. And what our data showed, so in this graph, here you see on the x-axis the gestational age, so how many weeks was the mom pregnant, and in the y-axis you see the difference in head circumference. The triangle, rhombus, and the rectangle show the different cutoffs that vitamin D of the vitamin D concentration. So, for example, the rhombus shows the lowest quartile, so the lowest levels of the vitamin D. The triangle, the ranges between 25 to 50, and the rectangle, higher ranges, suboptimal ranges, and the reference category is the x-axis, so the zero line. So if we interpret this graph, we see that mothers who had vitamin D concentrations in the lowest quartile, their infants had lower head circumference at 20 weeks of gestation, at 30 weeks of gestation, at 40 weeks of gestation, which leads to lower head circumference at birth. So some other findings from that paper, again, here we have the highest quintile as a reference, and we see that mothers that had the lowest concentration of vitamin D, so mothers that had vitamin D concentrations in the first quartile, had higher risk of delivering a baby preterm, so less than 37 weeks, had higher risk of having a low birth weight baby, and had higher risk for having a small size for gestational age baby compared to mothers that had optimal levels of vitamin D. So again, this is the power of a cohort study when we have the opportunity to explore, to obtain the exposure and then follow up the participants and determine the outcome. So we can see what is the cause and clearly see what's the cause and what's the effect. I need another volunteer to read the title. And actually, that was the paper that made me move here in Canada. So in this case, what's the exposure? Yay! And what's the outcome? So we say that infant breastfeeding and then school age. So why do we use a cohort design? Again, the same reason. We obtain the exposure data and then we follow up the participant and get the outcome data later in life. And I have highlighted in this figure or in the abstract, breastfeeding is associated with subclinical changes in kidney outcomes in childhood. If you remember David Barker findings among the first slides, I mentioned that the association that they observed were among the normal ranges of low birth weight. In this case as well, the associations that I observed, they were like infant breastfeeding. Infants that were never breastfed had lower kidney volume and lower EGFR or a marker of kidney function, but these lower values were among the normal ranges of both kidney volume and kidney function. And our hypothesis is that these subclinical changes may lead to a disease later in life. So this is the first exposure. We see that a response is happening, and then this response may lead. So if the exposure continues and we see already changes, it may lead to, in this case, chronic diseases in later life. So in the Generation R, we had information on infant diet from birth to 1 year of age. We asked if the mothers had ever or never breastfed their baby, for how long they breastfed the baby, if they exclusively breastfed the baby, and when was the timing that they introduced solid foods. And kidney health was kidney measurements were performed at the age of 6 years. We measured kidney size by determining kidney volume using ultrasound, and then kidney function using blood and urine markers. So what are the findings from this study? Not surprisingly, breastfed is the best again. Ever breastfed children had higher kidney volume, which a higher kidney volume means it's a good thing, and higher kidney function. It's better to have higher kidney volume and higher kidney function rather than lower, because then you are predisposed to disease. And infants that were breastfed for more than 6 months had higher kidney volume larger kidney volume at the age of 6 years. And we didn't observe any associations with age at introduction of solid foods. So as I mentioned before, that was actually the study that made me move in Canada, here in Manitoba, in Prodi Center, and in this amazing team of the Jets and the Blue Bombers. And I joined Dr. Azad's lab in the child study to try and understand what is the mechanism, what's in breast milk that influence the development of several diseases. But before going into details to those findings, I'd like you to show a video of the amazing child study. And unfortunately, I have this talk now and not a few days ago before December 30, because child study participated in another video competition from Child Health Research Day from Canadian Institute of Health Research. Sorry about that. But we still hope that it will be the winning video. So enjoy the child study video.
Imagine a world where allergies, asthma, and chronic illness are rare, treatable conditions. Better yet, imagine a world where these conditions can be prevented before they develop. 3,500 Canadian children and their families are helping to make that world a reality by taking part in a groundbreaking first cohort study called the Canadian Healthy Infant Longitudinal Development, or CHILD study. This is one of the largest studies in the world to look in depth at how genes and the environment interact to cause allergies, asthma, and other chronic diseases. Launched in 2008 with funding from Allergen, the Allergy, Genes, and Environment Network, and the Canadian Institutes of Health Research, the CHILD study has recruited pregnant mothers and their families, carefully studying them until the children are at least 5 years old. Researchers are looking at the effects of outdoor air pollution, dust, chemicals, and pets inside the home, as well as moms' and babies' diets, stress, and antibiotic use. This involves testing drops of the baby's blood and taking samples from dirty diapers. Environment Canada is partnering with the study to better understand the impact of traffic pollution on the development of allergy, asthma, and Health Canada is testing urine samples to measure levels of phthalates, a harmful chemical found in soft plastic. Research is still underway, And by 2017, the child study will have collected more than 500,000 questionnaires and over 600,000 biological samples that will be available to scientists for decades. So, what has the child study discovered so far? Research is showing that pregnancy, birth, and the first 100 days of a baby's life are critical to health and well-being. By just 3 to 4 months of age, almost all Canadian children have been exposed to at least one phthalate. Babies living in areas with higher exposure to air pollution have higher risk of developing allergies, as detected by skin testing at 1 year of age. Babies born by cesarean section have lower levels of important gut microbes compared to babies born by regular delivery. However, at 12 months, this difference is reduced if babies are breastfed. What's more, breastfed babies have been shown to have a reduced risk of childhood obesity. Now that the oldest children in the child study are 5 and the youngest have celebrated their second birthday, researchers are analyzing the data to find out what factors relate to health and disease outcomes. They are confident that their findings will influence public policy, parenting decisions, purchasing behaviors, and even urban planning, all designed to keep us healthier in a world where allergies and asthma become much less common. Of course, there is still much work to do. Today, 3 million Canadians suffer from asthma. 1 in 3 Canadians is directly affected by allergic disease, and 50% of all Canadian households are directly or indirectly affected by food allergies. These numbers are on the rise, and the child study with its 3,500 families will help us find out why, for this generation and the ones to follow.
So indeed, child study has brought world evidence and amazing evidence. The researchers we have, the clinical staff we have had done an amazing job in obtaining data, collecting data, following up participants in order to give us the opportunity and understand what is the cause and what are the risk factors, and try to improve the health of children. And so it's really something that we need to appreciate. So as you heard in the video, the child study is aiming to understand how do genes and environment influence child health and development. And again, it's a large population-based study, among the largest one in North America. It's located in four different provinces. So you see British Columbia, Alberta, Manitoba. The Manitoba site is really unique because we have participants from Winnipeg, but also Morton Winkler, trying to get the rural aspect in the study, and Toronto, Ontario. We have collected so many samples, biological samples, and so far, like right now, we're continuing with the 8-year visit, if I'm up okay. We haven't finished yet, but we're aiming to continue following up the kids. So this is another way showing the detailed information. So the data that is obtained in the child study, starting from home environment, diet, maternal and infant diet, maternal stress. But what is unique for child study, it's also the different samples that we have. So the breast milk and poop samples during different time points. Another way showing the huge amount of data that we have in the child study and the samples. And again, breast milk samples were the ones that brought me here, worked with Dr. Megan Azad and other PIs and staff of the child study. So when we talked about the advantages and disadvantages, among the disadvantages, we said that the cohort study are a bit expensive. So indeed, we need to have and obtain lots of funding all the time in order to continue the follow-up of the kids and their families, obtain the different samples, analyze the data. So it's really, it's an opportunity that we should appreciate. We also discussed about some inclusion and exclusion criteria when we saw the nurses' health study video. So we said that that the study population were nurses of a specific age. The child study also had some inclusion and exclusion criteria. So The pregnant women that were going to be enrolled in the study should be older than 18 years. They should have the ability to read, write, and speak English. They were willing to donate cord blood, and of course, we didn't include any children that were preterm. And we excluded children that had congenital abnormalities, children of multiple births, and children resulting from in vitro fertilization. We have asked lots of data. We have asked lots of questions, and we have obtained lots of data. We have asked questions about the type of the home, the age of the home, the furnitures in the home. We have asked mothers, fathers, and a lot of questions on their health during pregnancy, the mother, the medication, if she was smoking or not, what type of profession she had, diet during pregnancy. We have asked questions to the father, so the demographic, health, medication, smoking, occupation, but we have asked questions related to infant as well, which is the mode of delivery, medications, if the infant used any medication, if the infant had food allergy, eczema, asthma, how many times have he seen the doctor, has the child ever been to the hospital? Tons of questions, and only due to our clinical staff that was able to obtain all this data. So if the Generation R study was broad and had so many different outcomes, the child study approach was a bit different. So in the child study, they had a primary outcome. Asthma was the primary outcome, but however, they have obtained also information on several other secondary outcomes such as wheezing, sensitization, food allergies, obesity, neurodevelopment, and cardiometabolic health. So as I'm a bit short on time, I'll go a bit fast on these results. Some of my work in the child study. When I first came here, I wanted to see the role of human milk oligosaccharides in the development of food sensitization in infants in the child study. So again, the exposure, the sugars in breast milk, the outcome food sensitization in infants at the age of 1 year. What we did find in this study was that the overall sugar profile in the breast milk was associated with atopic sensitization. But what I want to draw your attention is in some statistical values. So here I have shown the results of a basic model, which means that I'm exploring only the relation of these human milk oligosaccharides or HMOs and food sensitization. And then I have shown an adjusted model, which again, I'm exploring the same associations, but now I'm taking into account many other factors, such as maternal ethnicity, maternal education, maternal diet, infant factors as well. So I want to emphasize with this that with cohort studies, we have the opportunity from the data that we collect to obtain information on different important factors that may alter or they may be important to include in the analysis. Another paper that was recently published was Determinant of Human Milk Fatty Acids, and I'd like one of you to read the title again. Volunteers? Thank you very much, John. So what is the exposure in this case? Do we have one exposure or do we have multiple exposures? Indeed, we do have multiple exposures because now we're looking at the role of diet in the concentrations of human milk fatty acids. We're looking at the role of genes. We're looking at the role of, we're exploring several social-demographic factors, maternal health factors, infant factors, and also environmental factors. So this is again the power of a cohort study that allows us to explore so many different exposures. And again, we are looking at fatty acids, but we have so many fatty acids in this case. So far I talked only on the prospective approach in a DOHaD research question, but we also cohort studies give us also the opportunity to look retrospectively to explore retrospectively a DOHaD question. And I'll briefly go through these: the Templar, or the Manitoba Personalized Lifestyle Research Program, which is a study established here in Manitoba, aiming to identify the complex interaction that exists between lifestyle, genetics, and gut microbiome. They aim to include almost 1,200 participants. I'm not sure if some of you have seen this bus around the city. Apparently not. But most of the assessment of the participants were done in this bus. So on the first day, the participants came in the bus, gave the consent. They did the consent process. They obtained the anthropometric measures. They did they measured blood pressure to the participant. They did other examinations, and also they gave them some containers to bring samples for the next day. So day 2 they did the remaining part of the examination that the study wanted to obtain. So some of the outcome measures were blood samples, anthropometric measures. They want grip strength testing, dietary assessment, DEXA measurement to obtain information on bone health. So Dr. Megan Azad led the DOHaD component in the Templar study. And I don't want to go into details because you know the amazing work she has done. But what I wanted to show you is another example of a DOHaD question in this retrospective setting of a cohort study. So last summer, I had the chance to work with Linda Lam, a medical student, and we were exploring the role of breastfeeding on bone mineral density. So now in this case, we had the adults, we measured their bone mineral density using DEXA scans, and we went back and asked the mother and the participant itself, so the participant and the mother of the participant, if they breastfed their infant, their child, for how long did they breastfeed. So detailed question about breastfeeding. And what we were able to see is that breastfed infants had higher bone mineral density, and this association was pretty independent of several confounders during adulthood. So cohort studies give us the opportunity to answer DOHaD questions in 2 ways: prospectively and retrospectively. We had the prospective examples from the child study and the Generation R study, both longitudinal studies. They enrolled infants, the mothers before they delivered their babies, and we continued following them up. We obtained several biological samples, clinical data, questionnaires. And we had the example of a retrospective study, the Templar study in Manitoba, which retrospectively assessed DOHaD exposure, but at the same time collected several biological samples, clinical data, questionnaires, and they had the opportunity to link the data with administrative data. So I'd like all of you to think of a research question, a DOHaD research question, and think of the best way you want to answer that question, either using a prospective study such as Child or Generation R, or a retrospective study such as Templar. So I hope I have convinced you a bit on the role of developmental origins of health and disease. And if you go out of this room, please remember that that's a very critical period, the first 1,000 days of life, but not only that, both prenatal and postnatal period. Even our parents and great-parents, they still have influence on our health. I hope that you now are aware of how to design a cohort study, what are some of the key components, the advantages and disadvantages of the cohort study. And I hope you never forget Generation R and the amazing child study, and use their data to answer your questions. And of course, I'd like to thank you all for your attention. And I'm happy to receive any questions.
Thanks for that. Representative of the Would you say other so-called general population?
Thank you, Dr. Baker. This is a very good question because even with the nurses' health study, I raised the issue that how generalizable may be the findings that we have out of our studies. So the child study, I'd say that in my opinion, it is representative because first of all, we're not focused only in one of the provinces, but we have the opportunity to enroll participants from different provinces. When we see, for example, the rates of breastfeeding, they are representative, although not identical, but still they are representative of the overall rates of breastfeeding in the Canadian population. Also, we have tried to include different ethnic populations. So, for example, in the child, although the majority are Caucasians, but we do have a large representative of Asian population. We do have a representative of First Nation population. However, as again mentioned, there is the possibility of selection bias because maybe the participants that are included in the child study or the Generation R study, they are the ones that are more, their parents are healthier, they are more interested in learning, or yeah, so there is the opportunity for a selection bias. But however, I would say that I would consider child representative. I'm not going to consider Generation R representative of all Dutch population because as the unique thing about the Generation R study is that it's a multi-cohort. So if in child we have almost more than 80% or around 80% Caucasian, in Generation R we have less Dutch, but we have a higher distribution of other ethnic populations.
How reliable of that?
Mm-hmm.
What is the extreme?
Yeah.
Breastfeed?
Yeah. Yeah, that's a very good question. And that was also one that is a big concern in retrospective studies. But usually researchers try to find other approaches how to deal with that recall bias, if we can say. So, for example, in that specific study, we asked mothers if they had breastfed or not their infants, but at the same time, we wanted to replicate those answers. So we asked the participant itself on the breastfeeding rates, if they were ever breastfed or not. So we tried to look at if the data that the mother and the participant itself agreed. And usually what you do in research, you also try to do some sensitivity analysis to see what's how reliable is your data, or if you have, for example, in cohort studies, we have to follow up participants, but we do have lots of follow-up. So we try to see if the participant that dropped out of the study, what was different for them. Was it the same social economical status, or was it the same distribution, like had the individuals enrolled the same birth weight, the same education level, the same income level? So these are some approaches that we try to follow.
Following up maybe women from.
Sorry, if I can.
Do you have any information on women
Mm-hmm.
respect?
So in the last study, if we have information on the ethnical background of and also.
Some of the results.
If I remember correctly, all the participants are Manitobans, but we did ask a question about ethnicity. And if I remember correctly, we did take into account the ethnicity of the participant, not of the not of their mother. But that's a good question that we have to check. I assume we checked it. It's a long time, but yeah, it did. May not matter in the associations that we observed. Of course. Mm-hmm. Yeah, that's it. Thank you all.